that would be helpful, I think. Okay. So this is the Outbreak Control Board, and Alex, you've got the list of apologies.
Yeah, we've got apologies from Councillor Bramble, Ruby Syed, Jake Ferguson, Helen Woodland, Steph Coughlin, and Ian Williams.
Thank you. And are there any declarations of interest? Don't see any. And questions from the public? I'm not aware of any. So then we turn to the minutes of the previous meeting. Are they acceptable to the city ICB? Yes. And the Hackney ICB?
Yep. Agreed.
Yep.
Okay, so then we turn to the heart of the matter. So I think, Siobhan, you're initially leading on this?
Yes, I am. Good morning, Randall. Hello, everybody. So I'm going to do a brief sort of synopsis of the paper that you received yesterday. Obviously, again, apologies for the late distribution, but that's just to make sure that we can give you the most up-to-date position on the data, etc. So it's been, I mean, so much has happened since we last met. It's hard to kind of imagine it was only a month ago. Really, it literally feels like a lifetime. But you probably will be aware that the main push really was to really rapidly increase the offer of vaccination to all adults over the age of 18, and in particular, because London has got a much younger population, our rates nationally were kind of lagging behind some of the rest of the country. So there's been a hugely increased focus on providing additional capacity for vaccines to be offered to the whole population, and in view of the 19th of July deadline around the possibility of lifting restrictions, etc. So it's been an extremely busy time for the local services delivering vaccinations. In the data, you'll see there's two areas really of focus, in the sense that we have seen a slow but steady increase in some of the more vulnerable cohorts, but small numbers again, in terms of making progress against the particularly vulnerable populations. And then we've also made really concerted efforts to increase our capacity locally, which you'll see in the pack. So that's about increasing our capacity to offer vaccinations in local vaccination centres, as well as with community pharmacy, and continuing to roll out our wide programme of pop-up and outreach events, which again, although particularly drawing in fairly limited numbers, but are having an impact, and are certainly getting the message out there in lots of different settings, and building those links with our community and voluntary sector organisations. And I'm sure will be things that we will be able to build on for the future. We have been one of our kind of difficulties really at the moment is stimulating demand. So we have got a lot of available capacity, but we are having difficulty filling it, and that's despite a raft of comms and activity. But we think that particularly around the younger cohorts, some of those more persistent ideas, I suppose, about why young people feel that it doesn't really relate to them, they don't really need to be vaccinated, is something that we think is affecting the really hard yards at the moment towards trying to fill that capacity. That's not something we're experiencing alone. It's definitely a problem across North East London. although I think across London it's varied, and there are other places that seem to be having a bit more impact on working effectively with young people. And that's something now with in partnership at North East London level, but also locally, we're going to really try and focus our attentions on, particularly from a communications perspective, but also trying to address some of the really, valid concerns, particularly things around fertility seems to be one of the major concerns around young people at the moment. We are offering lots of walk-in appointments now as well, so that, it's to try and make things as accessible as possible, to try and remove the barriers. We are also looking at other ways of stimulating demand by another round of activity around call and recall. And one of the things that we've agreed to do is centralise the call and recall function through a service that the Office of the PCNs are developing and putting in place. That's, we hope, will get started by the beginning of next week. So that's been a rapidly sort of put together component of the service, which we anticipate will, be able, there's going to be about 8 people in that team who will be able to do a lot of calling, and a lot of them are quite experienced people who've been involved in vaccinations in other settings. The XL team centre in particular, because they're downsizing that offer. There's been some workforce that we've been able to capture locally, which will help to, we hope, just add some capacity to going through some of those people that remain unvaccinated in the community. The other things, just to say, are care homes data. We have a much better handle on our data now. The local authority in Hackney in particular has done a huge amount of work focusing on trying to get behind the actual individuals from a staff perspective as well as from a resident perspective around what some of the barriers might have been to why people have not been vaccinated. And we are making good progress around reducing any of those people who haven't been vaccinated so far. There's more to do around domiciliary care, home visiting type care, but it's looking much better. And I think the other sort of steps for us now are thinking about whether we want to try and develop our own bespoke sort of roving model of a team that we can deploy to ensure that this kind of activity is maintained going forwards. The two big things really, I suppose, are to be cited on, and I know Sandra will probably pick that up, is obviously cases are increasing, so infections are increasing. So that's, for us, it's very important that we keep this momentum going around trying to increase the numbers of people who are vaccinated, because that could present us with particular issues as we move forwards. And then the next phase of boosters, really. So we're going to be having a kind of planning summit really at the end of July to think a bit about how we look forward now towards the autumn, how we're going to work with primary care and other providers and other parts of the system in order to ensure that we can robustly manage an extensive booster programme alongside a flu immunisation programme, and also an increasingly busy day-to-day activity sort of in primary care. Lots of stuff happening. There's lots of children coming forwards with respiratory viruses. You might have heard about some of that in the press. So there's a lot happening, and we just need to be really excited on that and make sure we're on the front foot going into the winter.
Thank you.
So I'll pause there, Randall.
There's a question in chat. Honor, I guess, wants some clarification on what you mean by roving.
So what I mean is literally we can take the vaccine to people individually. I mean, we are doing some of that work in terms of, or at the moment we're looking at some potential home visiting services around the over 80s in particular, but that's something that we're kind of piecing together through goodwill and cooperation across the system. But whether we should actually create our own service for a period of time, this is the next sort of consideration that we're thinking about, really.
Okay. And Councillor Kennedy has a question.
Yeah, thank you. One comment and one question, Randall. The comment is that improvement in the care homes, both in staff and in residents, has been driven by Helen and her team just literally doing individual plans for individual people and going and talking to each member of staff, each resident who's unvaccinated, and talking them very gently through what was the obstacle, why was the obstacle there. So that's been really intensive and resource consuming work to actually get there. But, you know, splendid that we are now, you know, government asked us to get to 90% of residents and 80% of staff, and we're there for the system on average, but a lot of very hard work to get to that. The second thing is my question, and that's about the interval between first and second doses. So I know officially the government brought that interval down for everyone now from 12 weeks to 8 weeks, but I know anecdotally from volunteering at the vaccination centres that people are turning up with a much shorter time span between the two doses, and it seems that the clinical leads are taking, you know, pragmatic decisions on site. But I wondered if there was any sort of official guidance around that, or we were literally leaving it to someone to try and decide if it was appropriate for that person or not.
Yeah, so at the moment we are in line with policy. Our policy is 8 weeks, and I guess you're right that on site there may be room for clinicians to take more pragmatic decisions in view of particular circumstances. But at the moment that's the policy, and we are keeping in line with that, despite that being quite challenging, I think, to be fair to people at the front line, where there's quite a lot of demand for that to be moved away from.
Randall, can I just pick up on that point? Just
because
I'm sorry to jump in, but maybe because others are going to make other points. So yesterday I was clinical supervising in Bocking, and so seeing people come in who wanted to do that. Two comments. One was the disappointing numbers of people walking in, very few. So there is that issue of you know that particular piece of comms just saying please walk in, and hopefully we'll have a lot of people walking in on the weekend. Big event at the town hall. But the other thing is that you do get some people coming in and actually where they've been booked in, and the call recall trying to continue to help support practices do that work as well as another kind of arm of recall. Call recall is constantly being worked on. Where as somebody who's been brought in who has an appointment, it's been made by their practice and it's less than 8 weeks. The policy was saying, well, they've clearly had a consultation about this. We haven't got access to their full medical record. There may well be reasons here that we are unaware of. So if they've been booked in, then you tend to just do it. There aren't very many, but you tend to do it. And that removes that potential disagreement, dispute, because he said, they said, this, you just do it. People who walk in, and there are people who walk in who are less than 8 weeks, say, sorry, you know, you've got to have a consultation first and be booked in if you want to have it less than 8 weeks. And I was called as to have a one conversation with somebody and a partial conversation, somebody who had already pretty much agreed to leave, saying, you know, unless there's something really exceptional and you can show the clinician on the site, you know, I'm sorry I haven't done this. I've just come into the country. I'm starting my chemo in 2 weeks' time. Here's the evidence from my outpatient letter. You would do it, you know, and you would be flexible. But most of the time, people who walk in who are under 8 weeks, they're asked to go and contact their practice and have a consultation and be booked in by one of the booking ins, and then they just proceed and have it. And those people who have booked appointments get done.
Thank you, Dr. Patel.
Yes, Siobhan, I've got a question around care homes and domiciliary visits and house mounts. So care home has got a good turnaround, and so many people die and so many new comes in, and some already had a first dose or second dose, and some haven't had any, and they want Pfizer, or they might have a first Pfizer, they want second Pfizer. So 2 or 3 taking in the care home is a challenge. So how do we address that for the Pfizer vaccines? Because there's not
Okay.
a big lump.
Yes, I understand what you mean. But that's not been brought to the attention of us before now. So you're saying, okay, so it's like a new admission to a care home where they
Yes.
particularly request Pfizer, which is obviously difficult to
yes.
manage.
Yeah.
I don't have the answer to that right now, Harin. I think we'd have to explore how we would manage that in that situation.
In my care home, which is a big 100, there's always every month 2 or 3 who needs Pfizer. That's a challenge, and they cannot go out anywhere to get it. So
Okay. Well,
issue.
I think leave that one with us, and I'll come back to you about that one.
Yeah. Thanks, Yvonne.
And I guess I've got a couple. You suggested that some other parts of London may be having more success in some of the age groups. And have we looked at what they're doing to see if there are things we could learn from them?
Well, yes. I mean, this literally was only discussed yesterday, Randall. So I know that South East London apparently have done some good work. I haven't had and I believe also in Camden have North Central London have commissioned an organisation that North East London is also looking at some of the work that they've done. So it's kind of in progress, that process. And obviously we're also we're going to look in some depth at the toolkit that Hackney has produced. The Young Hackney have done a piece of work as well. So we're going to look at how do we deploy what resource we've already got potentially as well, and then think a bit about how we join up or learn from other places too, because it is probably something quite bespoke that we need to put together. And once this sort of surge phase is kind of dissipated a little bit, we will definitely be wanting to do something more consistent and more ongoing around younger people.
Okay. And has the government told you when the booster program begins, and do we have clarity on whether you can combine it with the flu vaccination program or not?
No, not on the I've got the dates actually. So the dates are from the 6th of September to the 15th of December. And then it's phased in line with the JCVI guidance. So that, in line with what we had done before in terms of the priorities. And at the moment, there is no decision on whether we can do the flu and the vaccinations for coronavirus at the same time. That's not been confirmed yet.
Okay, thank you. Marianne, I think you've got the last question. Oh, the hand has gone away.
Sorry, I was on mute, sorry. Hi, sorry. Can I just ask, when we roll out the booster programme, we'll be using, I suppose, the intelligence we learnt the first time round. And I suppose the key thing is accessibility and ease of use and location, especially for city residents. So that's great. And the other thing is this issue around the second jab and the length of time between the first and the second jab. Obviously, it's really keen that we capture the younger cohort when they're minded to have their jabs. So is there flexibility? So, for example, I know that some who are keen to travel abroad, and the decision that if you have 2 jabs has encouraged people to get both jabs within the shorter period of time. And they will look online and see that 3 weeks between the jabs is recommended by the vaccinator. So if somebody does walk into any of our premises and asks for the second jab, but it isn't within the 8 weeks, will we allow that? And how can we capture England's win last night and encouraging young people, especially men, to get jabbed? Because we all saw the crowds, we all saw people celebrating. It was wonderful, fantastic. But I'm sure a lot of people in this room, their hearts sunk at the same time. And it's incredibly important that we utilise this historic moment in our history to really roll out that message that young people, especially young men, need to take up the vaccine. It's perfectly safe. So what can we do around messaging? Thank you.
Well, I suppose just to refer back to the previous question on the anything under 8 weeks at the moment is not mandated. So we, as a general, so we wouldn't be necessarily, we wouldn't be advocating deviating from that at this stage. That may change. Who knows? Things change all the time in this programme. Gareth Southgate says get a jab. Yes, Honor, that may well be a good tip. Yeah, so I guess, I mean, I completely agree. How do we capitalise on mood and momentum? And I think that is something that we will be certainly looking at in the work that we're going to do around young people. And I think that's, that is a valid point around young men, maybe in particular, how we think about working collectively, because that's a kind of whole system issue, how we're going to have to really pull together on some of that messaging to get it right, and also capitalise on that energy. But yeah, I think it will. We can definitely build on it, but I wouldn't expect that it would have massive impact straight away. But we can certainly build on and learn from what would be positive about it.
Okay, Mark.
Just going back to that the earlier second dose request from people on the basis of not a clinical kind of need, but I just want to get it done so I can get a help me to travel abroad or whatever it might be. So no, if people walk in, they won't get it earlier, because that started happening and got some traction in the press, where some sites were allowing that briefly, and because the data is all recorded electronically at the point of administration of the vaccines, very quickly noted by the powers that be nationally, etc. And you see, they will contact you. Your site will be contacted and saying, "What are you doing?" We expect a few people to have earlier jabs because of clinical need and other reasons which of exceptionality. But if you're doing it in a wholesale way, you'll get picked up, and they'll say that you risk your vaccine supplies because they are being targeted nationally at places to do the cohorts, to do the extra, and so and there was a big pushback nationally saying stop it, and we may change the rules and we may bring 8 down and give more flexibility, but at the moment you're not allowed to. So it has to be by exception. As I say, if you're booked in, you tend to get it because you've had a discussion, a consultation. If you walk up and can't prove exceptionality, then technically you won't. And that's the official guidance that we have to go with at the moment. And that's not, that's the guidance we have to work in. And it's more than guidance. It's the rules that we have to work within.
And just in view of the comments in the chat, I think maybe it would be helpful it may be that we've already made a start on the work, but actually perhaps next month, if I bring back the kind of updated communications plans and activities that we're going to put in place for young people. So that might be useful. Some of the some of the comments about the particular cohorts and also sites for all of that is under discussion and we're being thought about at the moment. So if I bring that back next time, that might be useful for people to see.
And also must remember there is some basis to why this is the rule at the moment. You get better long-term protection if you have your second dose at 12 weeks than you do at 8. If you're dealing with younger cohorts of people who will not be the first to get their booster in the autumn, far from it, then you want them to have longer protection at this stage by having a booster nearer 12 than 8. So to bring it forward too much, maybe cutting off your nose to spite your face in terms of the long-term protection for those people. So there's and as Siobhan says, this is constantly being reviewed and looked at, and guidance and regulations are changing fairly regularly. But that's some of the kind of basis to that sort of decision making. And obviously, it's not just about supply; it's also about immune response.
Okay, thank you. So I think we'll now turn to the data, and Diana, you're going to tell us about this.
Hello, can you hear me?
Yes.
Sorry, it's slow this morning. And in advance, I apologize for the background noise. I have an urgent issues with childcare, so there will be some toddler noises on the background, just so you know. Right, so I would like to start with this actually, just on the back of the discussion around vaccination. I don't know if you can see my screen. Please let me know if you can see it. Yes? Yeah.
Yes.
So these are the data from the Center for Disease Control in the US, and it's just showing, what it's showing is this kind of sage gray line is your cases, so incidence rate weekly, and the kind of blue purple line is vaccination rate. So for every single age group, and I appreciate it's a bit small, I'll try to increase it. So you can see for every single age group where vaccination rates rising, the number of cases is falling. So very clear relationship for every single one of them. So just to reiterate, it's so important to keep encouraging people to come through to vaccination. It could not be more important than that, especially in light of the government announcement that now we can go about our business from the 19th of July as always, as if we don't have an increase in the number of cases, which we do. So what is happening in Hackney and the City of London? We have seen a steady increase in the number of cases for several weeks now. And the last hike in cases was particularly large. So we had about 81% increase in Hackney and 63% increase in the incidence rate in the City of London. So we are now over 200 per 100,000 in Hackney and over 300 per 100,000 in the City of London. We'll look at the age distribution. So this is the chart we reworked our charts slightly. So we've got the previous data from older than 3 months, but you can still access it. I should have said in the beginning, you can still access all of the data here in the historical data, just to note that. But in terms of how cases are distributed, so we are still seeing that the highest incidence is in the youngest age, the young adult age group, so 20 to 39, and that's been just steeply rising since about beginning of June. The other age groups, the cases aren't rising as steeply, but nevertheless they are rising in all of them. So 0 to 19s and 40 to 59 now having quite similar incidence rates, with the latter age groups of 40 to 59 seeing quite a steep hike just in the last week. We are not seeing a very dramatic increase in our over 60s just yet, but I had a look at the hospital admission data this morning, and it does look like we're seeing an increase in admissions, and that's in line what's seen nationally. So many of you would have heard the announcement on the 5th, and Chris Whitty was pointing out that there has been an increase in admissions and deaths. Not a large one, but nevertheless, there is an increase. So it is very important that people go through to vaccination, and they keep testing as well, because we have noticed that, and the national data suggests that sometimes people, even when experiencing symptoms, they still don't go and test for a variety of reasons. Alongside the vaccination, that message around testing still needs to be reiterated to people, because it's one of the mitigating actions that they could take. In terms of distribution in Hackney and the City of London, so we are seeing different rates in different parts of the borough. The lowest are in the north, but they also have the lowest testing rates, quite significantly different from the Hackney average. And the highest incidence rates now are here in the east of the borough in Hackney Wick and City of London and around Dalston, Hoxton area. We had to change our legend actually last week, because the incidence has risen so high that it no longer, just the entire borough was just colored in blue. So we have now changed that to higher cutoffs, just so you can see the variation. And in terms of where we are in compared to other London boroughs, so we are towards the top of the distribution. So our incidence rate, like I said, is over 200 per 100,000 population, and that puts us among the highest incidence rates in London. And that is an ice cream truck, in case you didn't know. With testing, we haven't seen an increase in testing rates because we're seeing more cases, more people experiencing symptoms. It was only natural we would see an increase in the testing rates, but it's just the orange line that I would like you to pay attention to. So sorry, it's loading. And that is the positivity rate. So it's the proportion of tests that come positive. So while testing increased, but not as sharply, the positivity rate has just shot up since about the end of May. So it's now around 5 in Hackney and 3 in the City of London, but that is combined pillar 1 and 2. And when we look just pillar 2, so the community testing, the positivity is actually much higher at around 10 rather than 5. Vaccinations have been covered, so I'm not going to do that. And in terms of deaths, we haven't seen any coming through just yet, which is good news. But given a rise in admissions, we can't rule out that we might see some in the coming weeks.
Thank you. Are there any questions? Let's see. So, Marianne?
Yes, Uncle, I've got a question. So where we saw the graph of steep rise in age 20 to 39, do we know any statistics on whether they had a vaccine first or second dose, or they all had no vaccines at all?
For those people that have been tested positive,
yeah.
No, we don't have that information. We don't have the capacity or possibility, I think, to link that data. It would be an interesting project.
Yes, yes.
Okay. And Marianne?
Thank you, Chairman. The increased rates in the City of London, we've got the businesses are coming back. So obviously, when it comes to testing, it's not just residents. I just want to understand those figures. Are they an increase in the residential population, or is it also the business community? And also the clinics, clinics that they want to set up in the eastern area, the Tower Hamlets and my area, the Portstoken and Tower Ward area. Is there anything we can do to have something closer towards the city? Toneby Hall is a bit of a trek, but that community finds it difficult to travel to the Guildhall. So is there anything we can do to bring the clinic closer to encourage more of a take-up? Thank you.
I can actually answer at least part of that, and I imagine Sandra can follow up, but I know we're still trying to get a community pharmacy approved in the east of the city. I don't know where we are on the latest on that. Sandra?
Yeah, I'm happy to follow up on that. Just to answer the first part of the question about whether the cases that we're looking at in Deanna's presentation of the data are residents or commuters. They are residents, so all of the cases that are reported to us are linked to residential postcodes in the area that we cover. Having said that, we have seen a substantial, I won't use the word significance, we haven't done the statistics on it, but we've seen a substantial increase in cases and outbreaks being reported in workplaces, both in the city and in Hackney, actually. So it's a combination of there's increases in the worker population as well as increase in the residential population, but we don't have statistics about all of the workforce, only where it is a situation that would require an intervention like an outbreak or a cluster. In terms of the vaccination clinic, yeah, we are still trying to get another pharmacy approved. We have been told categorically several times that there will be no more pharmacies being brought on stream, that once they get to the end of the vaccination sprint, this will be winding down. But there may be another opportunity later when the programme opens up for booster doses from autumn. It's not really clear whether that's the final word, because we've been told that we were told the first time that it was the final one, and then there were another 2 rounds. So it may still be possible, and we're just going to keep pushing whether the door's open or not. And then the other thing is that we're still looking at the possibility of trying to provide a pop-up service somewhere in the Portsoken area, but we'd have to find suitable premises, and that's not as straightforward as it sounds. So Toynbee Hall is a good compromise for now, while we keep exploring other options.
We do have the pavilion at Aldgate that we could look at.
Yeah, absolutely. We can look at all of these premises, but it's just not a question of whether it's big enough. There are a number of considerations that need to be taken into account, and then it has to be approved by NHS England. So yeah, happy to look at any premises that people are able to offer, but the fact that there's somewhere that seems big and available doesn't necessarily make it appropriate to do vaccinations from, just to be clear upfront about that.
Yeah. Okay, Councillor Chapman.
Thank you. Thank you. If I can go back to, in a way, to Dr. Patel's question. As I read it, the government's strategy going forward is that we should rely heavily on vaccinations to protect us from a spread, as well as the impacts of the disease and death. I mean, is there anything in the data we are looking at so far that can give us any reassurance or otherwise that that's going to work?
Not in our local data, but from a national perspective, and you'll probably have heard this in the press conferences. What you can see that there's been a weakening of the link between cases and the more severe outcomes. So at the point last autumn when we had this sort of case incidence rate, we had a much higher proportion of those people being admitted to hospital, and much more burden on critical care as well. And in fact, we were really struggling locally and in northeast London, but not only in this part of London, or not only in London, in terms of ensuring there was sufficient critical care capacity and enough oxygen going around the hospitals to support everyone who was admitted. So for the same number of cases a week, now we're seeing about, and I may get this wrong, so forgive me if I get the exact proportion wrong, but I think it's about 1/10 of the number of cases being admitted to hospital. I'd have to check up on that to be precise. So although we can't say for certain from the local figures that we're seeing the impact of vaccination at national level, it does look like that's true, including with this Delta variant, which is more transmissible, and where in countries where people haven't had such a high proportion of people vaccinated, it's actually caused a lot of very serious illness. We're not seeing quite so much of that.
Thank you.
Caroline?
I think Sandra's maybe just answered it. I was going to ask for a picture of what admissions are looking like, and for want of a, well, essentially about staff resilience, capacity, and also, for want of a better word, I suppose, turnaround in terms of, you know, how effective treatment is, and whether we're getting people home again more quickly.
Well, my NHS colleagues are probably able to give you a more detailed answer, but we do have better treatments now, which is one of the things that is also sort of attenuating that link between getting infected and possibly dying, and also has meant, even since the last surge back in autumn and winter, that people weren't staying in hospital quite as long as they did during the very first peak and in spring last year. So and the other thing is that the majority of people who are being admitted to hospital now haven't been vaccinated at all. Some may have had one dose of vaccination, but most of them haven't had any, and they tend to be younger, whereas in autumn and winter it was middle-aged and older people. But I don't know if Mark or Siobhan want to add anything to that.
I mean, I think it is. I think it is all a challenge in terms of capacity amongst the workforce. Obviously, there's a big push from a recovery perspective, you know, in terms of elective care, waiting times have obviously substantially grown, and the numbers of people waiting has substantially grown, and just that sort of tension of trying to manage planned work when there's a possibility that you know, there could be an increase in urgent and emergency work is going to be, I think, potentially challenging, given that our rates of vaccination are slightly lower. And I think people are really, you know, potentially very exhausted by everything that's been going on. And you know, I don't think you can underestimate how much of a challenge all of these factors could be for people. I mean, we know locally that there have been a few, you know, a slight increase, as Diana mentioned, in terms of admissions, certainly to the Homerton. I mean, the system is still functioning fairly well in terms of discharge from hospital, and people are getting home. And like Sandra says, you know, treatments are much better, but then there is, you know, the modelling that's been talked about around the impact of long COVID, for example, as well. You know, that's another big ask of the system, you know, so that's another factor that could, you know, could really be something that we have to deal with going forward.
Okay, and Mark?
No, I think she wants to cover most of it as well. I was going to make the long COVID comment. It's a new condition and is yet not far from being fully understood. Maybe many conditions playing out, etc. So that is a significant issue for the younger cohorts when you've got many thousands of people being infected potentially. And the other thing is, of course, even when you've been doubly vaccinated at risk, it's, you know, an over 90% protection from serious illness and death, which is fantastic. But that, if you've got 100 people pre-vaccine last year in ITU, now you would have maybe 5 still there, doubly vaccinated, 10, and if you've got large numbers again, but hopefully the large numbers are mostly in the much younger cohorts, not the most vulnerable people in those cohorts 1 to 9. But anyway, so that there's still a risk even when you have been vaccinated, because not everyone develops the same level of immunity and immune response and maintains it for the same level. You know, it's about managing the risk really, rather than it's far from being binary in terms of get to, you're fine, guaranteed. You know, you've still got to be careful, and we've got to consider all these factors going forward.
And there could always be an even more challenging variant showing up. So, yeah.
Indeed.
I think we need to turn to the outbreak control plan now. Sandra?
Yeah, so thank you, Chair. So you'll have noticed that we changed the format of the report to make it easier, and more accessible. It was getting longer and longer and longer, and I thought that this would just make it easier. So hopefully you'll all have read it, and it's presented enough of the strategic detail to give you assurance that we're doing everything that we need to do. And the one thing I really wanted to draw people's attention to was that the community testing program is going to change. Well, it has changed actually from the beginning of July, so that we are closing the test sites where you can go in and get an asymptomatic test done, a lateral flow test done on site, and moving to a model which is primarily around community collect, where people can collect test kits from local pharmacies or the PCR test sites, and some other localities that we have enabled to do that as well in City and Hackney, like community centres, for instance, but so that they can then test themselves at home. And then the other element of the test programme is going to target communities where we think that access to testing and uptake of testing has been low for various reasons, including that their ability to engage with the programme, either because of the booking or because of the physical access to sites, was more difficult. So it's a combination of the testing teams doing more outreach and engagement and taking tests to people, and other people who can self-serve, collecting their own kits and testing themselves at home. Those are the major changes from the last report, and I'll just leave it for questions now.
Okay, Councillor Kennedy.
Listening to the radio at lunchtime yesterday, Radio 4 announcer said that the government was stopping free lateral test availability at the end of this month. A very worried government official called in and said, can you correct that, please? It's not that we're stopping at the end of the month, it's just that we haven't announced what's happening after the end of the month. But that sensitivity clearly shown by that incident, and actually have you had any indication, Sandra, that they're actually going to give some clarity on this?
So we had probably, I don't know, sorry, I've lost, over the last 18 months, I've completely lost track of time. So if I say it was a week ago, it could have been a month, but we certainly had both letter and guarantee of funding, at least until the end of September from DHSC. So we weren't in any way expecting it to end this month. It's just the transition from the previous model where people were expected to go to a test site and and kind of overlapped with Community Collect, which started some time ago as well, and now much more of a focus on Community Collect and then engaging with underserved communities. So it's not that we're stopping community testing, either PCR testing or lateral flow testing. The model for the lateral flow testing has changed.
Okay, John.
Thank you. Yeah, this is more about the concern that scientists have been raising about the opening up on the 19th of July. In particular, that they're saying this is highly risky and potentially we don't know what's actually going to be the outcome of it. So, and but given the fact we've been hearing today about the low take-up of vaccines in our area, although it's kind of improving, it still sounds like a highly risky activity to actually open up and encourage people not to wear masks and discourage social distancing. Is there going to be a local comms approach to what happens on the 19th, given the pressures that we're seeing in Hackney and the North East London?
Yeah, thanks for the question, John. Yes, we're absolutely aware, and we were aware and had been planning for and developing our approach to whatever announcement was going to be made. So we knew that restrictions, as in the stay-at-home restriction, was going to come to an end at some point, and that businesses that hadn't been allowed to trade legally were going to be allowed to begin to do so again, like opening up nightclubs, etc. So we knew that was going to happen, and we fully expected that it was going to happen, well, first of all in June and then from the 19th of July. What wasn't clear is what the government was going to announce on the personal measures, like wearing face masks, etc. But just because it's no longer a legal requirement to wear a face covering in a crowded place doesn't mean that that's not what people are being advised. So I just want to clarify something you just said. Even the government is not advising people not to wear face masks. They're saying we're no longer requiring you to by law. But what our local comms is very likely to say is that there's still higher levels of infection and it's still rising, and we have significant numbers of people who don't even have the protection of vaccination. But even for those people who have had who are fully vaccinated, as Mark was just saying, it's not going to give them 100% protection. And so we're advising that people continue to take these measures as long as there are high levels of virus in circulation. That could be for another 2 months or more. We don't know exactly when this is going to peak. And we'll keep monitoring the data and updating our communications and engagement with the community and through our community champions accordingly.
Mayor Glenville.
Thanks, Chair. I suppose immediate response to what Dr. Husbands has said is, do we think we've got the sort of capacity and the communications routes to capture that nuance? The sort of last 10 minutes of the discussion, I think, is quite nuanced, and it will be competing with quite a lot of national communications. So the subtlety of what we do and to whom and where may ebb and flow. Like just looking at the statistics that Deanna shared, you know, Stamford Hill is actually a place with relatively low infections. That was a place of targeted work at a previous stage in the pandemic. So this does change, it does ebb and flow, and different communities are impacted. So that's sort of point one. The second question was a genuine question rather than a more statement-based thing to Sandra, is we obviously have various variants circulating in the population, and there was some quite detailed, I forget the technical term, using the PCR test to map the variants, the profiling. There obviously new variants will emerge. It was quite a 6 to 8 week sort of time period, I think, between sort of seeing first variants and that surge testing that happened in Shoreditch. It may have been slightly shorter than that, and Dalston. I just wonder, has that improved? And from the discussions we've had, is that likely to be a model that continues after the end of the roadmap?
Thanks. Good question. So the first one around communications and whether we have the communications capacity to develop these nuanced and targeted messages. That's something that we've been working on all the way through, and we have actually put additional capacity into the communications team to work on specific parts of the COVID response, whether that's around testing, how to test, where to test, when to test, why to test, or vaccination, or what is COVID, etc. So we've been doing that work all along, and we've always had to some degree, work against some national messages which are not necessarily coming out from government, to be fair, but the media will either pick up a thread, and because it makes a good headline, they'll say things like, Freedom Day or masks off or whatever, and then and sometimes they're just completely incorrect because they may have misinterpreted something. So, and we can't control for what the national media or even people writing things on social media are going to say. We just have to keep putting out clear and concise messages, but make sure that we're also targeting various communities through the relevant channels in the way that we have done. And of course, we're still open to take questions from people to respond to their particular concerns. And what we've been doing with the vaccine program, for instance, is lots of live engagement and also just producing some videos that make it just more accessible for people. And we can continue to do that around various themes, whether it's why you should continue to wear a mask, and how do you protect yourself best when there's no more social distancing, etc. And then the other question around variants. So there used to be quite a lag between having the PCR test done and then the genome sequencing that would tell you whether it was a variant of concern or not, because there were so many cases linked to variants happening in London in particular. And because London is often, it's a major hub for people coming into the country, whether they're coming on their way to somewhere else or whether it's because we're such an international city. We did seem to have significant proportion of the variants in the country happening here, and so genome sequencing was switched on, as if you like, for all PCR tests in London some months ago. And in the course of doing that, they've increased the capacity in the sequencing labs, and that's massively shortened the time between the test being taken and the sequencing being done, so that you would know whether it was a variant or not, or which variant it is. And so it used to be something like weeks, and now it's just a matter of days. So we're constantly monitoring for variants, and if there are new variants, there are new variants all the time, to be clear. There are loads of variants that we don't talk about because they're not very widespread and they don't seem to be giving the virus a particular advantage. But Public Health England's scientific colleagues are all looking at those and saying, at this point, it's a variant under investigation. We're trying to understand what its impact is likely to be. And at the moment, there's just a very small number of variants of concern, which are the ones that we know have taken hold and they're more transmissible, or they cause more illness. The ones that we've now given Greek letter names to. And so far, there are only those 4 that we're concerned about. But I think the process for identifying a new variant, for sequencing all of the tests to understand whether the cases that we're seeing are related to variants or not, has massively improved since we first started discussing this a few months ago.
Thank you. I think we're going to end it there, so we can have a brief break before the ICB meeting. So I'll see you all in 5 minutes. Thank you. Okay, good to see people back. If we can now start the Integrated Commissioning Board, which will, during the course of the meeting, magically transform into the Integrated Care Partnership Board. And let's see, there's a couple of other small housekeeping items. You all will have in your August calendar the Outbreak Control Board and the Integrated Commissioning Board, and there was some discussion of whether we needed to have that, and it's fairly clear that we do need to have the Outbreak Control Board meeting. So we think we'll also hold the ICB or the ICPB, but it will probably be a reduced agenda, so it might be a bit briefer than usual. And then under AOB, we're going to hear from Susan Masters about the VCS assembly, the very successful VCS assembly that was held. And then we've just got 2 items of decision. We have the city board is in court as we start, but Ruby is expected to join us towards the end. She's in court this morning, and we'll do the formal approvals for those 2 decision items for the city ICB at that point. And with that, I think we can begin. And apologies, I assume, Alex, it's the same set of apologies that we had for the Outbreak Control Board?
Yeah, no additional apologies.
Okay, thank you. Declarations of interest? There you go. Susan, is that a hand on that point? No. Okay, I don't see any questions from the.
Sorry, I was sort of slow on muting on that one.
Oh, yes.
I'm a local councillor in Newham, outside of my role with Hackney CVS.
All right, thank you.
And I should have confirmed earlier that I was covering for Deputy Mayor Bramble, so apologies for not apologising for her apologies.
Oh, it's no problem at all. Thank you. Okay, questions from the public. I'm not aware of any. So then I think we turn to the minutes of the previous meeting. And are there any issues with that? Otherwise, I think we, the city will approve, as I say, formally later. Hackney can approve now, I believe.
Yep. Agreed.
Okay.
Yeah.
Agreed.
Okay. And we also have the action log. So we're just noting that. So then the big item, terms of reference for the ICPB and the Neighborhood Health Care Board. And Jonathan, you're going to be introducing this.
Thank you, Randall. So we've discussed the terms of reference for ICPB at a number of meetings, but we'd always said that we would try and agree the terms of reference for both ICPB and Neighbourhood Health and Care Board together. So that's what we're looking at today. At the last ICB meeting, there were a number of helpful suggestions in terms of changes to the terms of reference to ICPB, and they are set out in the report. So just to go through those, we were asked to put in a specific reference to the Nolan principles that's been added. At 5.12, we've made additional reference to reducing health inequalities. At 7.3, we've clarified the role of associate lay members in ICPB. 8.3.4, there's a specific reference to something that's always been at the heart of how we work in City and Hackney, so this equal partnership between clinicians, managers and the public. At 9.4, there is a change to the minimum number of meetings that's been increased from 6 to 9. And at 10.4, we've set out a mutual obligation for ICPB and the Health and Wellbeing Boards to report to each other. In the main report, we've also set out what is this sort of shared view of how the governance is going to work together. So what happens where in different parts of the system. So there's a real desire with new arrangements that at first glance can look quite complicated. There's a real desire to be very clear about what happens in each board or committee to try and avoid duplication and to avoid gaps. And I think in particular to avoid a situation where it feels that similar proposals or reports are discussed by pretty similar groups of people in different bodies. So trying to get clarity about that feels important in terms of how things work in future. I don't propose to say much more. And the one thing I would say is, which is quite frustrating. I mean, we've said in the report that obviously there are the changes coming in the new health bill. The terms of reference for ICPB have been drafted as best we can to allow for this board to continue to operate under the new arrangements. But obviously, as the bill goes through Parliament, there could be changes, and the guidance might mean that we have to make some tweaks. One thing we are going to do more than tweak, though, is the name of our partnership at a local level, and therefore the name of this board, because in the bill they refer to what was previously called the ICS Partnership Body. So if you recall, there's going to be an integrated care board or an ICS board at North East London level and everywhere else in England that is the sort of NHS part of the new structure. And then there was going to be an ICS partnership board which would have significant local government involvement and would deal with integration and the wider determinants of health. And that partnership body is now being called an integrated care partnership. So if we're going to have an integrated care partnership at a ICS level, at North East London level, then we're going to have to think about how we describe ourselves locally. But that's a challenge for the weeks and months to come. But it is frustrating that the language keeps changing at an NHS England level. And I know that integrated care partnership is a term that has been embraced around the country, and that's caused quite a lot of frustration, because what we really want to avoid, and not so much for us, but I think much more importantly for residents, is complete clarity over what happens where at a City and Hackney level and what happens where at an ICS level, so that they know where to go if they have an issue or they want to raise a concern. And I think some of this confusion around language is unhelpful. But Randall, I will leave it at that, and we can move to questions and comments.
Thank you. Right, Aaron, your prompt lock will. But you do have
a question for kind of future, because things will open up eventually at some stage. Would these meetings be always be virtual, or at some stage we'll move on to face-to-face?
I mean, I think that this meeting will follow the same sort of rules and procedures as other NHS and local authority meetings. I think it would be good as we try and form a new partnership and a new way of working to come together physically, but also there are sort of opportunities in terms of, we know that there are a lot of busy people involved in these boards, and there are some real opportunities in terms of accessibility, I think, in allowing a mixed model. But we'll follow the same changes to rules and regulations around how we hold meetings as the NHS and local government.
Thank you. Chris.
Jonathan, thank you very much for your work on this, and specifically thank you for taking into account all the comments that we all made last time. I think it's really heartening to see them taken on board and absorbed, particularly 10.4 and that relationship between the health and wellbeing boards, because I think that's absolutely crucial, that the City and Hackney Health and Wellbeing boards feel that they can ask things of and make reports to the Integrated Care Partnership board, and vice versa, without there being a hierarchy, as it were, between the two, because actually everyone's working towards the same goal, but in slightly different ways. And I think we should acknowledge that it's with the health and wellbeing strategies and the health and wellbeing boards that those much wider determinants of health, over which the corporation and the local authority have control, but which aren't matters specifically of health provision, but yet absolutely, as Marmot rightly said, are the wider determinants. Those places where decisions about that are taken can actually make requests and give reports back to the very specific, the health and care part of the system. But there are, as you rightly say, there's naming questions that we've still got coming down the line. There's legislation we haven't seen yet that might make requirements of us that we don't yet know. I agree with you. It looks like we probably need to work out what these place-based ICPs are going to be called, because if the ICS level wider partnership is called an ICP, you're absolutely right. We can't go calling it an ICP at all the different place levels, because no one will know where they are. So because there's so much fluidity, we had always said, quite rightly, that later on we would that we weren't setting any of this in stone, really, that we would we'd come back and look at it. So are we sticking stuff in the diary now so that in 6 months' time we'll have another look at these terms of reference and see how they relate to the legislation? I suppose at some point we'd like to fix them so that we understand where they're at. But I guess we have to be dependent on legislation. So one is the legislative timetable set, and two, where do we finally think about in terms of their timeline, of our timeline, being that we can have some sort of clarity and absolutely settle on what we're doing.
Thank you, Chris. I mean, there may be others who want to add to this. My understanding is that there's still a plan to have the new arrangements up and running in April. So ICS level, and clearly it's of huge interest to the ICS how things are shaping up in the various places. So I think getting things in the diary feels sensible. There isn't anything in the diary at the moment, but there are plans being developed for the transition at a North East London level. But I think we need to take ownership of what's happening in City and Hackney, recognising that it's a changing picture, and there's much more guidance over what happens at an ICS level than what happens in the place-based partnerships, and I think people have welcomed that. But whether that remains the case as the bill progresses through Parliament and people start to raise issues, we don't know. It's always possible that more detailed guidance, either from NHS England or things in the bill itself, will emerge as people raise concerns about what happens at a place-based level. But I think we should get time in a diary, and there's kind of two sides to it. One is what are the rules and regulations and what do we have to do, but there's also reflecting on how these arrangements are working for us. How are we working together? Do we need to look at how we arrange ourselves whilst adhering to the guidance? But I think Tracy and Siobhan want to come in.
Yes, Siobhan, you had your hand up first.
I don't know if I can actually add much more than what Jonathan said, to be honest, but I would agree. The timetable, as I understand it, is committee stage by sort of September, and that we are definitely not moving away from that timetable of April next year, and the appointments for chairs and accountable officers are going to happen in line with the timetable that was announced earlier this year. So I mean, 6 months doesn't sound very long, and it may be that we might have to do something iteratively, I think, as things move along, because there's a lot of planning and thinking going on, which I was going to pick up some of that later on the ICS update item, but I think that's very valid, and I'm sure Tracy's got some contribution around that too.
Yeah, Tracy, you had your hand up and took it down, but
yes, sorry. I mean, both Jonathan and Siobhan have said, so I won't repeat inane comments that just says, yes, we need a review towards the end of the year when the legislation is done. I'll also take the opportunity to apologise because my camera is not working and I cannot get it to work. Sorry. So I'll use it more to just say that. Apologies from me on the camera front.
Thank you. Okay, so I think we've reached the point where we ought to approve these terms of reference. And of course, as I noted earlier, we have a small problem of the city being currently in quorum. But let me ask the Hackney.
So Randall, are we? Sorry, it's Mark here. Are we just taking both papers together, the Neighbourhood Health and Care Board, or just the ICB?
Well, we were discussing them both together, but I was going to propose to vote on them separately.
Fine. Okay.
And of course, we did have that discussion earlier about the small change to the Neighborhood Health Care Board. And I don't know, Jonathan, where are we on that?
So I understand that Siobhan and Tracy had a conversation around that, and we're happy to make the small change. Is that correct?
Good.
Yes, I mean, sorry to interrupt, to come in. Yes, no, that's fine. And again, I think for both sets of minutes, there is an absolute necessity to review this once we're much clearer about the legislation, but also we've had the opportunity to run it for 9 months, so I think that would be a really helpful point to put in the diary, as you suggest, Randall.
Yeah, good.
And so just for people's benefit, the change was around the Neighbourhood Health and Care Board. The draft that you have in front of you said that it would report to ICPB, and it's been changed to will be accountable. So it's just consistent with the language that's used in the ICPB terms of reference in relation to our relationship with North East London.
Can I just make one other comment, because I think the discussion yesterday I hadn't completely clocked the working groups. The suggestion that the chairing arrangements of the FPC and the Quality and Outcomes Group, maybe we just need to kind of hold that slightly lightly on section 7.2, because the proposal there was that the finance officer who joins the Neighbourhood Health and Care Board would chair the FPC. Well, at the moment, because the FPC and the Quality and Outcomes have a formal relationship with the NEL CCG, so we can't detach that requirement. And of course, at the moment, Sue chairs the FPC, Sue Evans, and I chair the Quality and Outcomes. In regards to the latter, we've already been discussing about chairing arrangements and maybe changing that for the Quality and Outcomes group. But I think we just need to hold that in 7.2 as it's written. I'm not sure we can completely agree to it at this stage.
Okay, Tracy.
Yeah, thank you. So I think what was probably not appreciated quite so much in drafting of these was this transitional period and how strong that would be with regards to the North East London CCG. And there was I suppose when we were looking back 3 or 4 months ago, there's sort of this leap into the ICP system. And of course, there is an intervening period. So from your point, Mark, I would agree with that. And in some ways, these terms of reference are going to apply to that interim period, after which we expect come 1st of April that CCG's functions and responsibilities as they exist at the moment at the North East London level will be consumed into the ICS, and that would then precipitate different responsibilities probably at our level as well. So I would agree with you up until the 31st of March, and then we're going to have a conundrum about how do we lay that out, and some of that is in discussion with the ICS. So yeah, we should make sure that is clear.
I mean, sorry, Tracy, it may be just that where it says in 7.2.2, for example, the sitting at the ICP FPC the ICP financial lead officer will chair this group. Maybe we just don't actually put anything about chairing the groups yet, because that will be worked out, as you say, down the line in the long term.
Yeah, and as we've already seen and discussed previously, the actual meeting structure, the recognising the FPC reports to the area committee as opposed to that's important. So that needs to that relationship needs to continue.
And the quality and outcomes one as well, similarly, because that reports to Nell.
Yeah, the two statutory
and the area subcommittee as well. Yeah.
So, did you want to make an amendment and approve it, or?
Well, I was just suggesting the amendment would be on 7.2.2, would be where the second sentence says the ICP financial lead officer will chair this group, and on 7.2.3, where it says the ICP quality lead officer will chair this group. I just wonder whether you should just remove those two sentences, because as Chase says, in the long term, it's yet to be decided, and of course we will. But in the meantime, we've got an arrangement that we're working with.
Okay, so does anyone have a problem with that? No. Okay, so why don't we do that then? I see all the hands have disappeared. So can the city approve the ICPB terms of reference, subject to formally getting it later, and Hackney?
Yeah.
And
agreed.
Health and care terms of reference as amended. The city first, yes, and Hackney.
Yep.
Yes.
Agreed.
Yep.
Terrific. Okay, we're actually ahead of schedule, and this is the point in the meeting where we magically morph into the ICPB. So I don't know, do you feel different? Okay, and the next item is the election of chair. And I assume we should be able to do that, subject to formal ratification towards the end when Ruby gets here, under the new terms of reference.
Yeah, I mean, Randall, just to check, I mean, shall we actually? I've got a nominee for the chair and the deputy chair. Can I move to that?
Yes.
Because I'd like to nominate you to be chair, on the basis that under the transition from the ICB to ICPB, you are the incumbent for the next 6 months. It's a 6 month rotating post, and so therefore I think it'd be very sensible for you to take on the chairing for the first 6 months of the ICPB. So I just would like to nominate you and just look to someone to second that.
And Chris, see your hand up.
Yeah, that was in order to second Mark's nomination of you, Anderson. Thank you.
Oh, thank you.
Randall.
Yep. Okay. So is that approved?
Approved.
Approved.
Yep.
Okay.
Congratulations.
Well done.
Thank you.
And can I make a nomination to the deputy then as well? That be Chris Kennedy. And again, on the basis of continuity, Chris, as we know, you will hand the next 6 months chair in the ICPB to him under the tour we've just agreed. And it seems sensible that he would be your deputy for the 6 months preceding the 6 months he takes over the chair. And we've set up a pattern like that with the 3 co-chairs as we move forward. So just need a seconder for Chris.
And I'm certainly very happy to second, and it looks like Hunter as well. So, so we can approve that as well.
Agreed.
Thank you.
Yep.
So we now move on to the Inequality Steering Group, and Anna Garner, I think, is going to introduce this.
Chair, Anna's not available today, and I'm going to cover the item with Angela. If Angela's here, now I can't actually see her, but there's somebody whose name doesn't appear, so I don't know if Angela's here. She might have been waiting to come in at 10:40.
Coming on now.
Okay, great. So,
Okay.
hi, Angela. Just that's very timely. So, as you may know, I chair the Health Inequalities Steering Group, and we identified a number of priority areas for action, one of which we're going to talk about today because it's one of the first ones where we've actually been able to produce something that we can discuss more widely. And Angela's been leading this particular work stream, so it would be particularly useful for her to talk you through the slides. But the topic for today is about the tools and resources that we as a steering group have identified, as opposed to developed, that we could support the system with to make use of. The purpose being to enable people to think inequalities and embed an approach to reducing inequalities in their everyday work. So I don't think I have much more to say about it. I'll hand over to Angela, and the slides are all there for you to look at.
Thank you.
Did you want to present them, Angela, or just speak?
I don't mind. I can present them if that's helpful.
That's fine.
Yeah. Okay. Hi, everybody. Thank you for inviting me. I'm Angela Bartley. I'm a consultant in public health, and I'm based at East London NHS Foundation Trust. And I've been working with Sandra and the Inequalities Steering Group on this. So let me just. So I think what we wanted to do was just to come to you with some suggestions, well, to sort of show you the work really that we're doing, and just to talk you through. Can you see that okay?
Yes.
Yeah. Okay. Just to talk you through what we're hoping to do, and then I've got some questions for you at the end. It's a bit like a test, really. So, as you know, we've got the Inequality Steering Group that Sandra's talked about, and then one of my tasks that I made the mistake of volunteering for, I think I didn't look away quick enough, was looking at how we can really develop and drive a health equity approach across City and Hackney. So how do we really understand where those inequalities are happening within different communities, different populations, and different groups? And how can we get that to be a much more consistent approach across the boroughs? So we all know what inequalities are. I won't go through that, but we can see them within communities and across and between those different geographical areas as well. And also there's a particular people who are particularly vulnerable. So carers, rough sleepers, care leavers, and people with no recourse to public funds. So you can look at it at a population perspective, or you can look at it at a sort of social determinants perspective. So my task was, how do we develop and enable the system-wide, so the City and Hackney-wide adoption of tools and resources to embed a routine consideration of health equity in everyone's role? So how do we make thinking about those health inequalities, thinking about health equity as business as usual? So across the NHS, across local authority, in community groups, in voluntary sector, in our private sector as well. How do we make this just something that we always look at when we're looking at, are our services good? Are we working correctly? This is a logic model. I won't go through it, but we've started to kind of work on where we think what we've already got in place. So some of the points in green are where in the kind of work I've done with Anna and with Jane, is looking at how we, what's already available in City and Hackney that we could use. So there are quite a lot of equity tools available. We don't need to start from scratch. Which one works best for different organisations, or which one works best for City and Hackney? There has been some really good work already completed across City and Hackney around looking at sort of equity and equalities work as well, so we can build on that. And then the bits in orange were more about actually in talking to some of my partners across how would we make this work. These are some of the comments they came back with around, you know, how do we know this approach works? Like, why is it really important? Confidence to undertake some of the analysis. There's a perception, and maybe you know, some of us in public health have added to this, that you need a kind of public health consultant there to do it. You need a data analyst. You need quite complicated statistics to really understand the work, and it puts people off if you don't have that resource in easy reach. And also, how does this fit with other tools? So if we're doing our statutory equality impact assessments or statutory equality work, where does a tool around inequity fit with that? So we need to sort of consider what some of those barriers or issues are as well. And then we're looking to promote some of those tools, develop them or adapt them for City and Hackney, a guide on what to do, potentially look at some training around this, and also share examples of good practice that we know are happening across City and Hackney, and get people to feel more confident and engaged in this work. So that's our goal. So this is complicated, but basically, in chatting to kind of partners and in chatting to Jane and Anna in public health and in the CCG, at ELFT, we've started to look at this question as well, around how do we really increase our capacity and capabilities and organisation to understand inequalities better. And it's kind of, you can go around in circles and it can get very complicated. You can get very caught up in different meanings of the word equality and population health and inequalities and equity and everything else. But actually, we found it easier if we broke it down by what you do as an individual, what could be your role, what would you do as a team, what would a team do differently if it was very inequalities or equity focused, and what as an organisation could we do? And we've just added an extra layer, which is what would a system look like? And you've seen these slides, so it's kind of starting to just really spell out what does it look like if you're an inequalities focused organisation. And then mapped onto that are some of the tools you can see that are already there, where either it's already being undertaken. So some of those, workplace race equality schemes, disability race equality schemes, all of those, that data and all of that system is there. So how do we build on that? How do we kind of broaden that to look at inequalities as well, or equity of access and outcomes? And you can see we've plotted that against individual, team and organisation. And it's the system level, I guess, for you as an ICB that we particularly want to focus on. So where you have those assurance tools around equity or social return on investment tools or your performance reporting or a prevention investment fund, how are we using equity to understand and use that resource and the influence and power you have better? I just mapped out an example that I found useful when I've worked with teams at ELFT. If we kind of pick quite a small example and you just plot it against those different systems. So for this one, I've just looked at employment. So at an individual level is a team. So, do all our teams in the council, when we're working with clients, do we look at employment data? Do we talk about the importance of employment in terms of health and well-being? In our NHS services at ELFT, do we understand how good employment is such a key determinant of good health? Do we even talk about it with our patient groups? And then as a service, team, do we look at employment by gender, ethnicity, deprivation, mental health diagnosis? Are we aware of those inequities? Do we know how to make those connections? Do we talk, do we link up our service providers with our employment support? Is that the right kind of employment support? Do we really look at it and understand it? And then as an organisation, in terms of, say, if we're looking at ELFT, I'm sure at the council as well, what are we doing around inequalities in employment status? So do we look at pay band as well as protected characteristics? Do we look at, do we look at disciplinaries by some of those protected characteristics? Do we look at career progression, et cetera, et cetera? So are we a focused organisation that can support better employment and look at those inequities in access to employment and in the ability to progress into higher pay bands as well? And then are we working with those marginalised groups? Are we working as an anchor organisation? Are we trying to increase access to those jobs from different communities and organisations? And then at a borough and a system level, where does employment sit? Does it just sit in that kind of employment group within the council, or are we looking at it as a key driver for good health across the whole of the borough? Is there a golden thread around employment across all of our systems and workers? Are we awarding contracts with strong social value around local training and employment? Is that a big driver in how we employ? So it's again about that anchor approach. I could talk a bit about what being an anchor is if everyone's wondering what I'm talking about, but it's about taking that much broader social determinants approach. So there's different levels you can work at. So these are just some examples of work that people are already doing around equity that we pulled out. So BARTs in particular are looking at their outpatients. This is did not attend rate, and they've broken it down by ethnicity. So you can see the difference around, first face-to-face employment, virtual employment, and follow-up against various ethnicities. So white, Asian British, Black British, mixed, etc. And you can see the differences there, and they're starting to understand that better. And the more we understand it and use that data, the more we can start to ask maybe difficult questions, but questions that need to be asked around why is there that difference? Is it warranted variation? Is it unwarranted? And if it's unwarranted, what are we doing about it? And how are we thinking differently about our services? And then example from ELFT that we were involved in, we looked at our talking therapy services. So improving access to psychological therapies or talking therapies. And we did an equity audit on that service and looked at who was accessing that service, who was staying in the service for the whole of the sort of treatment session, and what their outcomes were. And we looked at that by all the protected characteristics and by deprivation. And we found that actually the biggest differential was deprivation. So the people from the most deprived communities weren't accessing talking therapy services. So we need to really think about, is that service, how do we make that service much more equitable? Why aren't people from those communities accessing it where potentially they have their greatest need? And you get that inverse care law where you get sort of not necessarily the people in the greatest need getting access to the services they need. So we really need to rethink how we're promoting and delivering that service. And then again, this was the work we talked about earlier. So as an organisation, what can we do to tackle inequalities? And that's at a team level and at an individual level. And we're building some training and resources for staff around these models. And this is just an example of a tool, the Public Health England one, which is a health equity assessment tool. So all of this, the questions you might want to ask is there. It's how we've used it across City and Hackney. So the questions for you are, I guess at a system level, what do we need to ensure equity is prioritised across City and Hackney? What are the quick wins which need a longer approach? What tools are needed and how do we encourage their use? And what's the role of the Integrated Care Board in this? What tools could you, as a first step, maybe adopt to improve system-wide consideration of equity? I'll stop sharing now, if that's okay. I'm happy to take any questions. I'll go back and clarify. I rushed it through for you there, sorry.
Thank you. Right, so challenging questions, but luckily some people have views. Let's see, Susan had her hand up first.
Thank you, Chair. Firstly, I'd like to congratulate Anna and Angela on their fantastic work that they've sort of presented today on a very, very important area. I think from the point of view of the voluntary sector, the question would be whether there could be a lighter touch version of this, given the sort of lack of resources involved. But also, I'm wondering whether there should be a standing item on the board as we sort of work through all the different organisations. And then, of course, we need to sort of look at applying it to our new integrated boards as well, which is something that wasn't quite sort of brought out in the paper. But I do think this is a fantastic piece of work and it's great that we're doing this.
Thank you.
Yeah, and we definitely don't. I mean, even for ELT, we do not want to make this into a PhD in statistical analysis of complex data. This is, you know, it is about there's different degrees of those tools. And I think the first thing is you start to just ask those questions. Do we know in our voluntary sector, you know, do we know with Mind? Do we look at who comes into Mind, who gets support from Mind? Do we understand it by those different groups and start asking those questions? And the tools literally, as Sandra will know, most of them, it's just a series of questions that you work through as a team or as a collaborative. There is some, if you need some data analysis, that's a slightly separate thing, but some of it can be quite a simple level to start asking some of those questions.
Yeah, absolutely. So what we're not suggesting is that the most complex or in-depth analysis needs to be done by everybody. What we're saying is that there are a range of different tools and the tools can be applied in different ways to suit the context. And so, you know, Angela presented it in terms of whether you're an individual thinking about it or whether you're a team or an organisation, etc. But also the different types of organisations obviously have access to different resources and different capacity to be able to deliver these sorts of things. But this is also where the Health Inequalities Steering Group work links with the Population Health Hub, which will be a source of support to do some of these things. So what an organisation in itself may not have the capacity, the appropriate capacity to be able to do a health equity audit, but could link up with the Population Health Hub, which could provide the relevant expertise to be able to do that. So at this stage, we're just saying there are a range of tools available. This is how we've presented it in a way that I think helps people to understand what's available and what they can, how they can make use of them. And then, of course, if they need support making use of those, we can support you with that in a slightly different way, as in not within the steering group, but through the Population Health Hub.
Caroline.
Very quick question. Obviously, really welcome these tools. I think this is excellent. I just want to ensure that inclusive language is embedded throughout, and to have an understanding of what reference, you know, where your source is for that inclusive language. I think we have quite an impressive inclusive language guide at Hackney, but it actually doesn't go into any great depth even within special educational needs, never mind in health more broadly. So I wonder if we need to do a bit of work around that, and have actually already asked colleagues in Hackney Education to look at that. So yes, that question around language, particularly around acronyms, which I saw dotted around, which you'll all be aware of conversations around some of those acronyms.
I'd really welcome that, actually, Caroline. I could link with you offline, because I think that is a slight problem. And I think sometimes, and no disrespect, Sandra, but I'm in public health as well, and sometimes we don't help ourselves by using quite complex language to describe things. And also the conversations we have around inequality, equity, equality, all of that. So I think anything that helps people, just if we can simplify it without losing the meaning, that would be great. So thank you, Caroline.
Yeah, absolutely, and I completely agree. And in fact, we have access to that guide, Angela, so we can make sure that that's included among the tools. But more widely, where there's specialist technical language, clearly we need to avoid using it in a way that is either alienating or can't be explained in simpler language, and nearly everything in the world can be explained in a simpler way. So there's no reason why we can't explain some of the public health work differently.
Okay, Siobhan.
Thank you. And thank you, Angela, for a very accessible presentation. I thought you made a really nice job of presenting quite complicated issues. But I guess what occurred to me from a system perspective is how this is a concept and is and your framework, the individual, the team, the organisation, the system, I think is something that's very helpful for us to think about how we apply these kind of complicated concepts to as a framework for how we want our services to be delivered and commissioned and planned for. And I think, you could equally apply it to something like sustainability or, any other concept in a way. And I think that what would be helpful is to use this as a way to sort of convey this is how we do things. This is what how our system operates. And I think that would be really helpful for us to build on in terms of the frame with which the City and Hackney Partnership functions. I mean, that would be my observation. So I think that was really useful. Thank you.
Honor.
Thank you very much. I think with all these things, we should follow the money. So I wonder if we could actually set ourselves the challenge of thinking about how much we're going to spend on this task. And I think that it would be complex and difficult, but no more complex than trying to change a whole system so that it puts addressing inequalities at the heart of it. And I think it'd be interesting to hear from Sunil and colleagues whether there is a way of doing that. Because really we should be thinking about how we invest more and more each year, because this is going to go to the heart of all of those wider determinants of health that we're so interested in. Thank you.
Thank you. Yeah, and I think that, what's going to be important is figuring out how to sort of embed this type of analysis in all of the things that we are asked to approve. Catherine McAdam.
Thank you, Chair, and apologies for having to leave the meeting and pop back in. So I'm an associate lay member for the CCG and the integrated care system, and my brief includes equalities and diversity and sustainability. I've been involved in this work for a few years now, and my perspective on what's the biggest sticking point for moving this work on is really about the accountability piece, which I think is about groups of people such as the ICPB being clear that whatever work is presented, the questions need to be asked, things that are presented need to be challenged, assumptions particularly, not just statements, but what lies behind statements. And if we're not satisfied that the thinking has done what is needed to be done, that we send things back. I feel too much, the processes that have been set up people do them and they do them in good faith, and then they feel like they've done the job. What then doesn't happen is that somebody sits down and says, so what did you learn and what have you done differently as a result, and how are we going to know that that this has actually made a difference? And unless people like us are asking those questions and actually pushing back and saying that's not good enough, then things won't change. And I think that's a really important kind of attitude and behavioral thing in a way about how we address this. You know, if someone came with a report that where the numbers didn't add up, we'd send it back. If somebody comes with a report that doesn't tell us what we need to know about how this is addressing inequalities, we should be sending it back. So that's one kind of thing. And the other thing is, if we're going to address this properly, it's not just about what we do, where we spend the money or whatever. It's how we actually carry out the work that we do. And I mean, this picks up a bit on the point about inclusive language, but if we're going to have the discussions, in terms of informing our decision making, then those discussions need to be more inclusive, and we need to think about how we do that and how we involve more people in the debates in a more inclusive way. I mean, we know, for example, that meetings like this are not accessible to a lot of people. A lot of people find it really hard to either attend. I mean, maybe they don't even get invited, but if they are there, they sit quietly because they don't feel that they've got a voice. And unless they're specifically asked to contribute in a way which makes them feel empowered, we won't hear what they have to say, and they may have some really valuable challenges for us. So in the People and Place group that I co-chair, we're going to try and work with an approach which is called Time to Think, which involves assuming equality of voice. Everyone in the room has an equal status and a right to be heard, and therefore we expect everyone to contribute. And there are ways of doing that, and I think we need to think not just about what we're doing, but also how we do it and how we make sure that the debates that we have are as inclusive as possible. Thank you.
Thank you. Sunil.
Thank you, Randall. I was just, I think, on a beat me to it a few minutes ago. So in terms of the investment available to this very important program of work, we've begun to have some conversations internally about this, and no doubt those conversations need to be expanded to Anna and Angela and the wider team. So, for example, the PINS program was paused 2 years ago for legitimate reasons. It was delayed for legitimate reasons. This features heavily in this program of work, and there are other elements to it which probably no doubt need investment. So maybe worthwhile taking away an action to talk this through and asking Angela and Anna to bring an update back later on in terms of how we drive the investment underpinning this program of work going forward.
Thank you. John Geeb. John?
Yeah. Sorry, I'm coming to this this discussion quite late, and I was very struck by we were discussing tools to raise the subject in a myriad of levels and about a myriad of inequalities, and it'd be quite easy for this to become a huge industry, it seems to me. So my suggestion at a system level, what should the board be doing? What could it do most usefully? Would be to try and set some measurable targets for the next 3 years on specific inequalities, which it would then request the teams to produce a theory of change for each of those, which we would then monitor. In other words, to try and bring this down to certain specific goals.
Yeah, what I was sort of suggesting earlier, which I think doesn't exactly fight with that suggestion, but maybe does a bit, is it seems to me that what we need to do is for each of these things that we're asked to approve, we need to understand what it's doing for this. And so it should be part of the report for each program as it comes forward, rather than sort of picking out a few that we think we could do something about. But I mean, maybe both could be done, but it seems to me that unless we really, it's a bit like when inequalities impact assessments were brought in for local authorities. You know, that for a very long time it was box checking and not much more than that. And I think some authorities have gotten a lot better about taking that seriously. But I think, you know, we don't want this to be some separate exercise. We want this to be embedded, I think. But others have, I'm sure, other views. Angela, you wanted to, I think, comment on that.
And yeah, I guess you've just hit the nail on the head. So, and I might not have been clear about this. It's kind of a continuously circular piece of work. So it's not just you do the analysis or you ask the questions and go, oh, that's interesting. It's you then measure it. So I talked about it with the Ambassador at BOTS. It's like, how do you get this in the same way a clinical team would be looking at their DNA data every month, or there any other performance data? So for the talking therapies equity work that we did at ELFT, you know, in that team, are they still looking at all of that data? Are they seeing what they're doing differently? Are they using quality improvement methodology to change it? So it is about what do you then do about it and how do you keep it on track, rather than you've just done a one-off piece of work that was kind of interesting and you put it aside and carry on as normal. Yeah. It becomes part of your business as usual, and you're held to account as a team and as an organization on where you are against that target. If that makes sense. And it's an inequalities target or an equity target. Yeah. It's not a kind of one-off piece of work you do and then move on and carry on as normal.
Yeah, absolutely. And I would add to that because inequalities are pervasive, and the you know, the underpinnings of that, you know, poverty, housing, worklessness, or, you know, poor quality work, etc., are pervasive. You can't just pick one type of health inequality and say we're going to address the gap in between these groups and use that as a target. You have to understand that what's driving it, and therefore that it's not going to go away unless it's all addressed, and therefore you need to address it in everything you do, but not as a tick box kind of screening thing where you just say, okay, we thought about inequalities and then we're going to plow on, or even we thought about inequalities and we've taken this one step towards reducing them. It is an ongoing thing because there will always be another group or another dimension of inequality that you can tackle and should tackle in order for us to provide the most equitable services and also get the most equity of outcomes.
Right, thank you. Paul.
Thanks. I mean, just picking up on some of these themes, the other thing, I was quite struck in the model that the behaviour and management actions box wasn't there at system level. And I think there might be something for us about really thinking as we go forward, what are the behaviours and approaches that we really want to encourage? So, you know, taking the point about what is the inequalities impact of all the things that we see at a board like this, I think there's something really important about, as I say, what behaviours, what ways of working are we trying to encourage? To pick up some of what I think Catherine was saying, if I heard her right, you know, how are we supporting co-production to happen, people to find solutions with us, and how does that already support the work on inequalities?
Yes. Laura.
I'd like to make a connection between Honor's comment about follow the money and Paul's behaviour comment, because I think they may be at the heart of how this board needs to start to think about this a bit differently as we move forward. So in my mind, I can think about the money in three ways. The first funds the sort of infrastructure and processes and capacity to enable us to look at this, and that's what Sandra and Anna Garner and Angela have been putting in place. So that's really good news that we're starting to embed processes that give us the ability to do this. Sunil was then talking about some specific initiatives that I'm not quite sure I fully understand that may also support the inequalities work, but the bigger potential gain and the bigger behaviour.
Oh, you've muted yourself, Laura, just as you got to the good bit.
Sorry, the bigger potential gain and the bigger behavioural challenge, I think, for us will be to start to look at this across the entirety of how we invest our resource for to tackle inequality in the pervasive way that Sandra described. So not just about a new few $100,000 of investment that's coming to this board to be signed off, but are we seriously sure that every penny that we currently invest is enabling us and supporting us to tackle health inequalities and those wider inequalities, because they're so intrinsically linked, in order to give our population the best possible life chance. And there's there are millions and millions of pounds sat there that we don't scrutinise, and we ought to. And the biggest behavioural success for us will be, I suspect, when we decide to move money from one place that isn't demonstrating that to another place that can demonstrate that. And when we get to that, I think that will mean this board has started to succeed.
Indeed. Thank you. Is there anyone else who wants to comment on that? I don't think we'll be entirely answering your questions today, Angela, but I do think we should, we should start trying to answer those questions. Sandra, you wanted to?
Yeah, thanks. I wanted to come back on a couple of things that contributors have said. So going back to what Catherine was saying about accountability, and picking up Susan's point about this being a regular item or a regular feature of this board, I think that it would be helpful, and we may not be able to get to it today, but for us to think through what does that mean, because I think just having regular reports back from the Health Inequality Steering Group is not going to be, it's not going to serve the purpose of having a regular conversation about health inequalities and what we're doing as a system to address them. So that's added another question in a way, but I think it's just a useful question for us to think about, and particularly it's picking up a couple of points that people made that I think were really valuable points. And then also linked to what Catherine was saying about, well, it was almost like, walking the talk in a way, so that we're not just talking about inequalities, but we're being inclusive and working with people, and picking that up in picking up the point that Honor made in the chat about quality of relationships, and so at an individual level, not just in terms of how health and social care workers and voluntary sector partners might work with individuals and the quality of those relationships, and whether those relationships are actually inclusive and see a whole person and not a member of a group, etc. But also, what does that mean in terms of the quality of relationships that we have within the system, including around this virtual board table, and how the quality of relationships we have models that the idea of inclusion and everybody being equal and everybody having an equal voice. I think there's something for us to think about there, both in terms of the work that people do and that we support or sponsor through the ICPB, but also about how we work with each other. So yeah, sorry, more questions. A bit of a philosophical conversation today, but I think it's all really useful stuff for us. Thank you.
Yes, Mark.
Just a comment really. It feels like, in terms of setting the culture and the expectation, well, the culture and the ways of what we expect work to come forward that we receive here, and actually the expectation on what we would expect to see, actually ultimately we've put ourselves on notice. I really feel kind of strongly that it's down to this group to actually be consistent in saying, actually, I think we probably do need to do a bit more here. I think we need and those relationships within this board, and having that openness, because we all have other areas we work in and are responsible for, etc., etc. So I think I kind of sense there's a collective kind of, right, you know, if we're serious about this, it comes down to us changing our behaviours and making sure that we do attend to this and look for the missed opportunities or whatever else in terms of work that comes here, where more could be done to address inequities, inequalities. So I kind of think it's quite. I was just struck by I feel like that collective responsibility quite strongly here amongst us.
Yes. John.
Thanks. This is kind of a related point. It's been a really interesting discussion. Also at the City and Health Inequalities Group, we look at, we've got a watching brief on the digital divide. And currently we have nobody who actually leads on that issue in ICP. And we kind of need that if we're going to actually tackle this issue, because although the group has a watching brief, nobody's actually kind of owning it or pushing forward actions on digital divide. So I'm not asking people now to kind of tell us who that is within integrated commissioning, but I do think that's a question that we need answered quite quickly now, because this is a kind of key issue in terms of kind of, if you are going to be improving people's lives, people behind on the wrong side of the digital divide need to have some representation, and so we do need somebody at the ICP level to actually say they're leading on this issue, and so we know who we can ask things of.
Okay, Siobhan.
I guess I just would, picking up on what Mark has said, and I think the sort of additional questions that Sandra's proposed, I think that we probably do need to spend a bit more time as a board and also as, you know, organisations thinking about how we are going to collectively mandate and address these things. And I don't think we necessarily know the answers right now, but we probably, I mean, this is becoming quite a developmental sort of discussion, and it may be that there are a number of other things culturally that we want to embed in our system, and some of the points that Paul made. I think that we need to spend a bit of time coming up with the proposed solution to how we're going to do it, and I think that might be something we have to factor into the schedule, really, not just at this level, but in some of the other forums that we're running, and maybe it's a good indicator of some of the other things that, I mean, just thinking particularly around some of the co-production stuff and the sustainability things that I'm aware of that we need to think about across the board, really. So we probably do need to spend a bit of time formulating how we're going to really enact it, and we might need to put it in the schedule.
Yeah.
Perhaps, Randall, we should maybe come back with a proposal about how we're going to do that formally at some point.
Yes, it might even need sort of development date as opposed to, yeah.
And Randall, can I just say the last thing is at a development session about how where resources, energies, money, etc. is finite. How do you make the difficult decisions sometimes?
Indeed.
When we wish to do more than we can do, and you know, that sort of stuff. It's really hard, and trying to do work on some, you know, some real life examples coming through as business comes this way would be great, but also it's something to do in a development session as well.
Good. Well, very, very helpful discussion. So I think we better move on now to the next item, which is the update on child and adolescent mental health. And I think Amy Wilkinson is going to lead on this.
Hi, thank you. Okay, yeah, so this paper is here in response to a request around a bit more information in terms of mitigations and where we're at in terms of the impact on the pandemic and lockdown on children and adolescent mental health and services. We've also got Sarah Wilson here today from ALFT, who's the Clinical Director of Specialist Services, for any specific questions and to give you a now and a clinical perspective. But the paper really outlines the impact that we've seen compared to what we would normally see in a year. So the areas that we're particularly worried about are our complex cases, eating disorders, the amount of increases in presentations, but also the complexity, just holding that in mind, and particularly 16 to 24-year-olds and that younger adult age group. We've put in a range of mitigations, which I think they're on page 78, as a system in response to this. Some of these were directly around the pandemic, so digital approaches, working on single points of access, but some of it was quite responsive in terms of a tier point 3 pathway for those children that need it, a crisis, extending the crisis offer and a bereavement service. And on the other end of it, and I think we'll talk about it a little bit more when we look at the strategy discussion that's coming up, have tried to roll out WAMs further to increase our impact in schools, and at that more preventative universal end as well. And that's definitely the direction of travel. But I think probably at this stage, over to Sarah. I don't know if you wanted to say anything as well before questions.
I think the big thing for me, I have to say, sadly, I'm not the clinical director, although I wish I was. I'm the service director for CAMHS in East London. And I think the big thing for us is about sort of recognizing how the pressure on services across the system during the pandemic, how services have responded together, I think really well in the face of some real challenges, and the way that this is really pointing us in the direction of greater integrated working across the sort of child mental health and wellbeing system. And I know you're going to talk about the proposed mental health and wellbeing strategy, and I think there's so many good things in there about how we can work together to support children and young people in Hackney. A lot of the developments that have taken place are really, we're being pushed in the direction of crisis. We're being pushed in the direction of people coming through the door and how we deal with those increased crisis presentations, young people presenting with multiple needs. But it's so important that we're also doing the networking, that we're also supporting children and young people as early as possible, that we're continuing that focus on working with school-age children, supporting children as early as possible, and also thinking about how we extend and really work really well with primary care as well. The other piece of work that I think is really important to talk about is the co-production. So there are lots of initiatives going on in City and Hackney to listen to children and young people around their needs. And we've recently had a huge conference in North East London, which had about 300 young people and stakeholders talking about what was important to them in terms of their emotional health and well-being. And there's such strong messages in there around, I want to tell my story once. I don't want there to be a postcode lottery. I want services to be integrated. I want to be able to enjoy and achieve. So I think that as we move forward, we kind of need to be able to be flexible. We need to grow services in an integrated way, and we really need to keep listening to children and young people about what their needs are. And apologies, my camera is giving up the ghost, so if I come up, I shall flash pink and stripy.
Yes, I think we saw a bit of that earlier, so I know what you mean. Lots of good cameras today. Right, so Sandra.
Thank you, Chair, and thanks, Amy and Sarah, for that overview, which is really helpful. So I think this is a good opportunity for us to test out our commitment to reducing inequalities. And so there's a lot in here about the increase of the burden of mental and emotional trauma and ill health in young people. And Sarah mentioned the idea of young people perceiving a postcode lottery, but there's not really much in the paper about what you're planning to do in terms of ensuring equity, both in terms of not just equity of service provision for those children and young people who get referred into services, but thinking about the ones who are less likely to be referred or less likely to have help-seeking behaviours in the first place, and how you respond to that in terms of reducing the inequalities there.
I think maybe if I start, I guess in terms of the service provision, I think it's very much what Angela was talking about in the previous item, about looking at who we're accessing, and making sure that we're carrying out sort of targeted interventions as well. So thinking about working with children, looked after children, thinking about children with disabilities, listening to young people and hearing about their experiences of difficulty in accessing services. There's something about being targeted, but there's also, again, for me, it's about early intervention, and it's about sort of universal intervention. So thinking about the whole life course approach to emotional health and well-being. So starting with our perinatal services, starting with our midwifery, starting with our health visiting services in City and Hackney, and parenting support. So it really is very much starting at that ground level.
I think that's a really useful challenge, Sandra. And also we have piloted sort of a range of services over the last couple of years. So a transitional service for Black, African and Caribbean heritage young people up to 25, an Orthodox Jewish commitment around WAMs in their schools, and it's sort of quite a variety of things. And I guess going into this more closely integrated phase is a chance to think about what we want to keep, what's still missing. And I think we have a young Black men's mental health work stream, which is a great opportunity, and I think probably not used that as much as we could have during the pandemic. And I think there's a structure there to push it forward and explore it better.
We've also recently commissioned through the CAMS Tier 4 Collaborative, which is the organisation that's now managing the scarce Tier 4 beds, so the inpatient mental health beds, a needs assessment, which actually Angela's team has carried out, which is going to report shortly, and is really looking at the use of CAMS resources, access to CAMS resources, barriers across the boroughs that we're serving, and also particularly thinking about who is are we over treating certain groups, are we under treating certain groups, so that will very much feed into the thinking within City and Hackney as well.
John.
Thanks. Thank you very much for this report. It's really interesting and a fantastic amount of work going on in this area as well. I was looking on in terms of the main report on, I think, the second page. There's the trends for the CAMS referrals. It's clear that the for 2021 it's much higher. And I'm just thinking about in terms of kind of the pressure that may be on young people coming in terms of kind of the government opening up, they're not going to be vaccinated, all those sort of issues. Are you expecting this to kind of keep growing, and do you have the capacity to manage a continuous growth in this area?
It's certainly a trend that we are seeing across London, and it's not showing signs of abating at the moment. And I'm afraid, yes, we are expecting it to keep going. I think there are also real pressures on the system in terms of physical health, and in terms of capacity within our acute trust colleagues to be able to deal with people presenting in crisis, increased COVID infections, increased respiratory disease infections, and how the whole system is able to respond to that kind of seriously unwell end. So I think it is it's got to be a real mixed response to thinking about how we can make our systems more efficient, how we can be much more joined up. So so many young people, you will have seen in the report, are presenting with very, very complex needs. And from an ALF perspective, when we're looking at the data, we're seeing where people might have been presenting with one or two needs, they're now presenting with more complex needs. So the join up with social care, the join up with thinking about with looked after children services, the join up with youth justice, the join up with the acute with the Homerton Trust is so important. We've got to work really well together and have really good escalation procedures, and try and avoid just being drawn towards the real crisis end by still paying attention to, what happens if somebody walks into the GPs and asks for help. How are we supporting our schools teams to be able to feel resilient and to support parents and families when they're coming in with problems? It is going to be a real challenge, I think, and resources are being increased, and we're really positive about that. But of course, we're going to say they're never enough, because I'm afraid there aren't. But we can make the system better if we work together better and use the resources in a more integrated way.
Let's see. Councillor Woodley.
Thank you. Bearing in mind the issues around digital inclusion, and who's, I guess, not captured here, I'm really interested in the data that's been presented around Couth, and also in how it's going with Silvercloud and Helios, and wondering how much understanding we have of how young people have come to those online platforms, whether it's, I assume, through schools on the whole, and I guess with a view to perhaps the initial surge in September of referrals, whether we're preparing for some sort of relaunch of these systems this September, and have a good idea about how to kind of encourage more. I suspect that some schools will have done, or hubs, youth hubs, whatever groups, will have done a really good job of getting their young people to feel a sense of trust in that system, and others, and obviously I'm thinking about people like the Orthodox Jewish community that already have an issue perhaps with going online, and general trust and authority, perhaps if that's not a horrible assumption, how we're basically broadening access to that. And then the other area I think was around eating disorders. I've heard anecdotally through casework of young people with special educational needs, particularly around autism, having eating disorders where they haven't presented that in the past. And I wonder if we have an understanding of that increase in eating disorders in terms of who is presenting with that.
Shall I take the digital, and Sarah, you take the eating disorders?
Right.
Sorry. So I think in terms of the digital, we're really encouraged by Couth, and they do capture great data. So it's been in place for about a year now, and it's really, really interesting to see who's accessing it. And the profile accessing it is really different to what we see accessing our CAM services and more general services. So that's encouraging. We've really only just launched Helios and Silvercloud, so we don't have good data for that yet, but we will keep an eye on it. And it was something that we had planned anyway, and we sped it up because of the pandemic. But I think it's just one string to our bow in terms of what's out there for children and young people. And we're really conscious that almost a quarter of our children and young people are in the Orthodox Jewish community, and what we do with them, hence the work with schools. The CCG also funded actually a clinical service for children and young people and their families just from the Orthodox Jewish community through the pandemic, and that's a partnership with the Homerton, so that's getting up and running. So you're right, we'd like to really relaunch in September when schools go back, but also in line with the strategy and the really crucial time that Sarah mentioned, which is this coming together of a possible third COVID surge, the respiratory illness, and still seeing quite significant levels of CAMS presentations. So yeah, definitely. Thank you.
And
Yeah.
I think it's a lovely idea as well about considering relaunching the offer around September, and that's certainly something that we should be talking about. The other thing to mention around digital is that we're doing, we got some short-term transformation money, and we're going to be appointing two people participation workers, so service user workers, to specifically focus on developing the digital offer from a young people's perspective. So how do young people, how do they get their information? What's useful for them? Because we can say, well, we look at Facebook, and they'll be like, well, nobody looks at that under the age of 40. So it's really hearing from young people about what's the best way of reaching them, developing those digital platforms, understanding, like you said, about how they're using things like Couth. And that's being done across the, that's going to be done across the ICS, because it feels like there's an awful lot of conversations going on about digital, and we kind of need to bring together the expertise and really be driven by young people. In terms of eating disorders, yes, you're absolutely right. So there is a stream of work being led by my clinical colleagues looking at what's going on in terms of eating disorders. So there are the kind of traditional eating disorders like anorexia or bulimia, but there's also this real growth in children presenting with disordered eating, and very much as you described, and it's looking at what treatments are appropriate for those young people, looking at how we train our staff in order to be able to work with disordered eating, look at how we support young people and parents around that. So I can't answer your questions about why, other than there are so many things going on in people's lives and so much structure has gone, and it's about thinking about the impact of all of these unprecedented things on children's functioning. But it is a real thing. We've got some great experts in our eating disorder team. It's a tiny team, so it's an East London team, probably has about 9 people in it, working across all of the 3 East London boroughs, and we're developing that and very much looking at how we can bring that eating disorder expertise to all of the different, to Hackney particularly, and we work very closely with the Homerton as well, because often young people will need to be admitted to paediatric units as part of their treatment and part of their, whether it's about refeeding or around their other complexities.
Okay, Mark?
Thanks, Randall. I suppose one comment I had comes back to a bit about the resources question. Having a sense of in the paper about the need, a sense of terrific kind of description of all the activities that are going on. But I suppose it's the next stage is well, how much is what's going on meeting the need? How effective is it, and what are the gaps, and what are the risks, and what are the inequalities? And I appreciate it's very hard because you can't measure all the things that you want to know about, so we don't want to go down an alley of just measuring, reporting things just because they're measurable and missing out on the important stuff. But nonetheless, having more of a sense of that within the papers, and then saying, right, well, we need, collectively, we need to do more. And what's part of doing more is more resources, and if they're not going to be, we have to think where that would come from, etc. And just having the flow of that story, because it is great to see so much activity, but I was left wondering, what is the impact? Is this good enough, or do we need, we need more? If so, more in what areas? And I guess resources in the in the general sense is just finance, but it's about people, isn't it? I'm talking about resources in the biggest sense.
I think that's really helpful, and we like all of the health system did a really flexible and quick response to a crisis, really, an increasing crisis, and that kind of stepping back and doing some proper analysis about the gaps. We need to do that now and think about that going forward, which is useful. I would say on the resources, there's a lot of national transformation funding. It's never enough, but in terms of one of the key things that we're struggling with, and I'm sure Sarah will support this, is the actual staff resource and the capacity in the services, and the fact that staff are tired, we are losing CAMHS workers. There's quite a lot of turnover. We have some vacancies. So bearing that in mind and thinking about how we grow more staff and more staff capacity is really crucial.
The pressure on staff is intense, and that awful feeling. I don't know, it's not very scientific, but the awful feeling about not being able to meet need and having people wait and having people in distress, and then multiply that by the fact that we're talking about children. There's something that's very, very difficult, and I think it's not much fun working in the front line in children's social care and in mental health services and in acute services at the moment, as you're all very much aware. So I think the resources are pressured. I think we could use them better, and I think that would be my really big message. There is a really reasonable amount of investment going into child mental health and wellbeing in City and Hackney. There really is. And we're going to have some interesting data coming out soon from a capacity and demand piece of work that again we've been looking at across northeast London, where you'll be able to see kind of relative levels of investment and see that actually there's a reasonable amount of money going in. It's how we use it, how we make the system better and smarter, the clinical leadership of that service, and obviously we need more money.
Okay, Susan.
Thanks, Randall. You've already sort of referenced some groups that are disadvantaged, and this is a point that I wanted to sort of pick up, whether there were other groups that were disadvantaged, because obviously the voluntary sector can have a big impact. I mean, you were talking about the need to work smarter. Well, the voluntary sector sort of plumbed into those communities, and I mean, just looking at our own networks within the CBS in Hackney, I mean, we have 70 organisations in our youth network alone, and then 476 organisations in children and families that can sort of both be put to service. So I'm just wondering what plans you have to sort of work with our sector.
I could certainly say from aspirationally, the developments, the integrated approach to working in City and Hackney very much involves the third sector as well. So I think you'll see in the paper discussions about developing a single point of entry or single point of access. So bringing together those organisations that are very much part of the child mental health system, and making sure that they're part of it, and that we're supporting them in terms of a sort of umbrella approach, and that we can use all parts of the system safely to provide the right care. So I think they're in there, and I think that this vision about integrated working very much involves the resources of the community, in the same way as we might be thinking about school nursing resources or health visiting resources or educational psychology resources, of things that are going on around schools and communities.
Yeah, there are quite a lot of partnerships with voluntary sector agencies delivering specific parts of the CAMHS system. So we mentioned a couple of them earlier, and I think it's about how we think about mainstreaming those going forward and identifying gaps linked to Mark's point as well. But they're a very strong player in the CAMHS Alliance, and we've got some really strong work happening with the community.
And Honor, I'm glad to see you put your hand up, because I was going to call you in anyway, because you've been very active in the chat. Honor?
We can't hear you.
Here I am chatting away just to myself, actually. I'm saying it'd be no surprise to Amy that I've got things to say. I mean, essentially, of course, this is absolutely right, this and the subsequent paper. I just feel, though, that we haven't really honoured the idea that children are born, and most children are born and brought up in families. And we have something about whole family. Family is the resource, and I really, and it's not a minority sport, I'm going to say it again, this notion of most children who live with parental discord and domestic violence and abuse, which has exponentially increased over the pandemic, are appearing in CAMHS. And unless we have an child and adolescent mental health service that is able to understand the impact on children of this and have something to say and do about it. We are missing a trick. We did a survey in Tower Hamlets. 40% of the clinicians' cases that they self-identified had parental conflict as one of the deepest troubles affecting children. These children may also have had a conduct or behavioural disorder, mental health issue as well, but nevertheless, there was something about that family environment that was difficult, painful, and quite toxic for children. It goes on to affect them and their life chances. We've got the DFE about to publish a report on the damage to children's lifelong earnings relating to early exposure to conflict, which is to do with grade suppression at GCSE. You know, I would like us to be brave enough to take this on, and I have hectored Amy, indeed probably fairly bullied Amy about this, but I just long for us to write it bold. And I think we don't write it because we're not quite sure what to do about it. There are lots of things that this system can do about it, most of which they're doing already, but I would just like us to set the child in the context of its family. The way the reports are written is as if the child is an entity on their own, reified and alone. They're not, they're there with all the complexity of relationships, and I'd like us to be brave enough to attend to those too. Thank you.
Thank you. As that was the last comment on that, and then we have the next item, which this obviously rather naturally leads into. And we're asked on the next item to note the final draft, consider any further amendments, and approve publication and dissemination. And I suppose in light of the discussion we've just had, are there views on whether we're really ready to finalize this?
Don't need to say yeah. So maybe this is sort of this has been quite a long time coming, and it's been around the system for quite a long time, and has been out for formal consultation for 3 months. And I think we really just want to get it out there in terms of the vision. So I'm really happy to take on the comments that you've got today. It's a final draft, so we can still work things in, and bearing in mind what Honor's said and what Sandra's said and what other people have commented on. It's not too late, and that's why it's here for you to feed into. But yeah, all your comments are really welcome.
Honor.
Then I should just content myself with saying thank you, Amy. It's immensely helpful that we've got a chance, and I would love to do some work with you on it. Thank you.
Great.
So what are we sort of suggesting that maybe a bit more work happens and it comes back in August for final approval, or I mean, how do you want to proceed on this? I know you want to get it out. I do appreciate that.
That's up to the board. I mean, I'm happy to work offline and then publish, or happy to work offline and then bring back and publish.
Views? I think maybe people have popped up. Rob was there briefly.
I was just to say, if there's time to bring it back, we probably should bring it back.
Yeah. Andrew?
Thank you, Chairman. I was just going to concur that we should bring it back. I think we can have a quick look, take on the points that Honor's made, but also look at how we contextualise children within their wider networks, not just their families, their friendship networks, which is what I think we've also tried to do.
Good. And Chris? Oh, hands down. Okay.
Chris, you were muted.
Oh, sorry. Yeah, I took my hand down instead of unmuting myself. Agree with the previous two comments about bringing it back, and I was just trying to look through the 5 to 18 section in the strategy. I think there really is something about trying to talk about mental health in schools in the same way as we talk about physical exercise in schools, and the same way we talk about nutritional, and actually thinking of them as a whole rounded health learning experience for our young people. And I'd like to see more emphasis on that in the strategy. Thanks.
And Caroline.
Just thinking about activities around publishing it, we're going to have an early years strategy launching at the very last day, I think, at very end of August. So, you know, we'll hopefully get some attention for it in September. There's early help review. I want to make sure that all these 3 areas of work makes sense in relation to one another, because they're going to have very obvious crossovers. So I wonder if you are okay with it coming out at the end of August, early September, instead of, I assume you were trying to push it before the end of July, whether we have an opportunity to just have a sort of sidebar meeting and look at how those 3 areas of work correlate. If that just feels unnecessary extra work, then ignore me.
You know, that's completely fine. I mean, it's here for your comments, and whatever way is the best way to do that. And August is fine. We have worked closely with Donna Thomas with the early year strategy, and also in part of the early help review. So hopefully it's not completely jarring with what we're doing there, but yeah, definitely happy to pick that up.
And I saw a hand up from Marianne, but it's disappeared. Did you want to come in?
Well, it was just I agree with Honor and Chris in particular about the preventive work in the schools. Otherwise, we're going to be on this treadmill forever. We need to address the issues early on and talk about mental health and build the resilience in our young people. It's now becoming more noticeable of the detrimental effects of mental health, with children also contemplating no returns. So I think it's vitally important that we jump on this wave. This pandemic has given us an opportunity. It's pulled back the rug. We know there's been the issue for many years. The schools have been struggling for years. The increase in rates have been rising, and the services have been under stress. And I think this is a real opportunity for us to turn everything around. So I would agree with Honor, and have the paper coming back and doing everything we can in terms of preventative measures as well.
Okay, so we'll
Thank you.
Thank you. So Amy, we'll bring it for approval in August, and you'll make some further changes with the discussion we've had today. Thank you. That's really been very helpful. So if we can now move on to the NEL ICS update, and I think that's you, Siobhan.
Hi, yes, it's really just a brief item, just to kind of acknowledge some of the kind of external things that we talked about earlier on today, actually, in terms of when we were looking at the terms of reference, some of the activities that are going on nationally and then in London and at North East London, and just to acknowledge that to the meeting. You may be, I know a number of you are involved in some of the North East London discussions that Marie Gabriel is leading around what the future of the ICS looks like, what the Integrated Care Board will look like, and then just really to flag that I'm conscious that the first draft of our system development plan was submitted to the regional office, I think at the end of June. So that was a very early kind of picture of what the ICS functions might be, etc. But I just wanted to highlight the fact that this process is really starting to take shape now, and that we locally obviously want to, as part of our transition planning, think more creatively and sort of systematically around what that means particularly for North East London CCG people who are located in City and Hackney, and what the future for them locally is going to look like, how we're going to support the work of the partnership on an ongoing basis, and really to indicate that work will start really very much in earnest now, I think, and that at North East London level there'll be lots of discussions and ongoing thinking around what the future of the North East London ICS will look like. And whilst I don't have a paper today, etc., I just wanted to acknowledge that these things were starting, and that to really flag it to members and ask a little bit about what might be useful from your perspective about what you would like to see here in terms of some of those developments, and how for me to make sure that you're kept informed through this forum as well as your other forums that I know that you're obviously all connected with already. So that was just really the purpose of the item today.
Chris? You're muted.
Did the same thing again. Yep. What we didn't talk about earlier is what you've just touched on, Siobhan, is that we've got such great experience and ability at our local, what was our City and Hackney CCG level, that's now our area committee. And I guess my fear is that when the ICS body replaces the CCG and there no longer is any CCG, whatever form of tuping over happens, tries to pull people up and spread responsibilities over wider areas, and I'm worried that expertise at the City and Hackney level and knowledge of the people and the place gets diluted. And I suppose the question is, what can specifically the local authority do? What can this board do now in terms of how we plan things to try and hold on to as much of that knowledge, expertise as possible?
Thanks, Chris. Yes, I would agree. That is something that we need to be mindful of. Obviously, the kind of arrangements that we have at the moment with the area committee and the delegation is a CCG delegation. It's not an ICS delegation. So there will be a sort of need to revisit some of that conversation about what sits best where in what part of the system, and that obviously will then require resourcing, and there will be a requirement, I suppose, for the resources in the system to think about supporting the development of provider collaboratives, supporting the work they want to do, as well as supporting the work the ICS might want to do, then as well about supporting what happens at the borough or the place-based level. And so I guess the kind of requirement from ourselves is to it would be helpful for me if we were able to kind of take forward, and I know Tracy and I are very keen to do this with partners, about how we might deploy some of that resource in a local infrastructure and a local system team and local support. So some sort of expectation that we come back with a proposal around that would be probably helpful, I think, at this point.
Absolutely. Thank you.
Yeah.
Okay, if there aren't any other questions, I think we'll move on to the finance report. Sunil.
Thank you, Randall. So as everyone will have probably noted, this isn't an integrated finance report this time round, simply because LBH and City of London don't undertake month 2 reporting, but we will actually bring a fully integrated report back. Hopefully it's the next meeting. So the report you have here is the City and Hackney ICP finance report as at month 2. I won't go through all the presentation deck slides, but I will say that the first slide gives an overview of the system position, which is break even, and we'll also say that the CCG, the ICP, are still operating to emergency financial arrangements in terms of receiving half-year budgets, half-year allocations for the first 6 months, and then a second set of half-year budget stroke allocations for the last 6 months, and a planning cycle in between. but based on the first year allocations budgets we've received, we are on plan to deliver a break-even position. And I'll just leave it there, really. The information is quite high level. Monthly reporting tends to be quite limited because a lot of the cost and volume data tends to be incomplete, but we've taken a prudent approach, risk assessed the financials, and believe we're on track to deliver a break-even position relative to our funding.
Good, thank you. Any questions? No. Then I think we go on to the risk register.
Hi, Randall. It's Matt here. Just to flag, so we've got page 131 for the 3 risk registers we've got this month. In those papers, there's 6 red-rated risks across those 3 work streams. None of those scores have changed since last month, but the risks have all been reviewed. Obviously, we had a discussion on CAMS relating to risk number 18 from Amy's team earlier on the agenda. And we are aiming to launch a revised risk register in September. Work is underway with colleagues, partners, and the NEL team as well on getting that up and running for the September meeting. Happy to take any questions back to the work streams or answer anything I can.
Any questions? No. Okay, thank you. Yeah, I'll be very interested in seeing the new version. Okay, we've reached AOB, and Sue Masters is going to, under this, tell us about the VCS assembly that was held.
Thank you very, very much. Firstly, I suppose I should say that I know Jake will be really disappointed that he wasn't able to be here in person to sort of update the board himself. I know how much hard work he sort of put in over a long period within the voluntary and community sector, but also with the statutory partners in this room. But on June 15th, Hackney and City's voluntary and community sector held its inaugural assembly, focusing on a topic that has been very much at the centre of this meeting, looking at emotional well-being. We opted for emotional well-being over the more general umbrella of mental health because we felt it was more inclusive, less clinical, and it covered the different shades of issues that were being raised by our many forums and sort of special interest groups. So the meeting was chaired by Vanessa Morris from Mind in City, Hackney and Waltham Forest, jointly with Rosemary Jawara from Beersheba Living Well, Dr. Sandra Husbands, who we've been hearing from a lot in this meeting, gave an address laying out the picture in Hackney and City. And then everybody was split into 11 breakouts, each one dedicated to a particular area of experience, such as LGBTQI or young people, people with learning difficulties. And we considered 2 main questions. What emotional well-being needs have been uncovered by the pandemic, what's working and what's not. And then more importantly, in the second half, we looked at how we could build emotional well-being, taking into consideration the impact of racism and discrimination. So coming back to another topic that we've been looking at. I mean, this is all about the enabler model, and I'm sure Jake's spoken about this at previous meetings, the importance of getting the voluntary sector, who've got at the heart of the experience of service users, to share their experience of what isn't working in our systems and their sort of particular concerns, but then also what they can do, sort of either working within our communities or in partnership with other voluntary bodies or our statutory partners to sort of address these issues. Now, out of these breakouts, each one came back with 3 headlines from their conversations. All of that information is now in the process of being decanted into a business case, which going forward, I'm sure will sort of bring many solutions to the table. And I'm sure myself or Jake will sort of look forward to bringing updates to the team going forward.
Oh, Randall, you're muted.
I'm sorry. Got all the way through, but not quite. Thank you very much, Sue. That was very, very helpful. And I thought the assembly, that I unfortunately was only able to attend a part of it, but I thought it was really quite well done. We now have reflections. Anyone? No one wants to reflect. Oh no. Okay, in that event, well, I'll just Honor, thank you.
I can't resist.
Yeah.
I think we today have thought about some really hugely important things, and I think we were much helped by the quality, as I always say this, the quality of the papers, and I still can't get over the difference in the life of the ICB, the quality of the papers that come, and some of the gentle provocations. I like it when we're asked questions that we have to then think about and take responsibility for, and I think that really helps us frame the debate. It made me go back to the terms of reference and how we're going to manage ourselves and our meeting behaviours, and I think we arrive very quickly at consensus, and we're probably rather like-minded folks. And it did make me wonder about where we have real philosophical disagreements, and whether this board has to get a bit better at teasing some of those out, really, because we can't all end up thinking the same. I'm sure we are persuaded by weight of evidence, but nevertheless, I think there are intrinsically different positions, and I think we need to get better at colonising those and holding on to them, because I think that will, if we're brave enough, lead to some richness of debate, even more so than there is now.
Thank you. Catherine.
Thank you. So this is my first meeting, and I apologise for the fact that I wasn't here for the whole meeting, but I just kind of echo what Anna said to a large extent. I think it's been great, fantastic papers, great debate and discussion, but I guess just picking up the point I made earlier, I think it would be great if we could spend a bit of time thinking about how we work together and how we really challenge each other, because that's where we're going to, I think, get the added value of having all these very different voices around the table, is if we encourage that ability to challenge and question assumptions and all of that. And that may mean working in a slightly different way, rather than the sort of standard, here's the agenda, here's the paper, presentation questions. We may need to introduce some kind of slightly more flexible ways of having those debates. And I guess that's part of the whole development of this board, but would be great if we could have that as an aspiration. Thank you.
Yes. Jonathan.
Thanks, Randall. And you and I discussed this with Mark yesterday, but I should have mentioned it when we were discussing the terms of reference. But I was proposing that I spend some time over the summer meeting up, either virtually or in real life, with board members, particularly new board members, to discuss some of this. So I think it would be useful to come together and discuss some of this in a sort of development type session at some point, but also to have sort of some more in-depth conversations to answer any questions about the role of the board, which is obviously wider than the role of ICB to date, but also to get a sense of the meetings, how they're structured, and what we can do to support people so that they can be as effective as possible on the board. So I'll be contacting people to set up those discussions over the next few weeks.
Great, thank you. John Keith.
As a newcomer to the board, just created, I thought it was a very interesting meeting. I got to learn lots of stuff from of what was going on, and I realized I sort of joined a conversation which has been going on for years, so lacked a bit of context. just one sort of just comment. They're quite long papers, quite discursive papers, and they were good for telling me what was going on and broadly why. At some point, I think we should sort of draw out of them the decision points, if you like. And they may not be decisions we can take in this huge gathering, but we should at least know, you know, what are the options that people are discussing and deciding between. I think that would give it a bit more bite, if you like, and perhaps in terms of make challenge a bit easier. I mean, I felt that quite a lot of this was presentation of good stuff which was happening for good reasons. There didn't seem to be any decisions to be taken, and so on the whole you got a very positive response. But there are some choices to be made. So I suppose as we move forward, I'd like the choices that are being considered, debated, to be a bit clearer.
Right. Yeah, and I guess I'd just like to sort of note the ICB in passing. I think we did do some good work there. We were beginning to actually challenge on a fair number of fronts, and then sort of COVID arrived and things got diverted a bit. And then on top of which, they were even more diverted by the big reorganization that we're all engaged in now. So hopefully, you know, we'll hit the ground running here as a care partnership board and get back to, you know, making real progress. So thank you all for what I thought was a really helpful, useful meeting. See you all.
Thank you.
All right, thanks, Randall.
Thank you.